right, so neuro assessment. 4 parts to neuro assessment on your study guide. The first one is, what do you see there?
Mental status.
Mental status. Mental status is fantastic for us in this class because we've been doing mental status exam basically from day 1. So what are you asking or eliciting from your patient all this time that's part of mental status?
If they can identify themselves, like name and date of birth.
Exactly. Are they aware of person, place, time, and situation? That's your oriented times 4. Keep in mind when we say they're oriented times 4, we're also saying they are AAO times 4. AA means awake and alert. So be careful because there's people that are oriented times 4 that aren't awake and alert. Somebody may be drowsy or lethargic, so I'm asking him the questions and he's answering them. Yes, I'm at PBA in the hospital, but it's like, Norman, stay with me. Where are you? Oh, I'm at the hospital. And then he kind of dozes back off. I would not consider him awake and alert, but he's still able to be oriented towards times 4. Okay, so that's that. The other thing you want to note as your patient is speaking back to you is their speech. Okay, do they have clear speech? Can you understand what they're saying? They're not slurring their speech. Their words aren't garbled. You can understand what they say. So that's the only, that we've all pretty much been doing except maybe commenting on the speech. Last thing you're going to add in that's actually new is memory recall. Okay, so memory recall is your short-term memory, your ability to remember 3 words over a short period of time. So after I go through my introductory script, I'm going to say to my patient, Norman, I'm going to give you 3 words to assess your short-term memory. So as I say each one, just repeat it back to me. And then later in the assessment, I'll have you recall these words and say them again to me. Okay? Ball.
Ball.
Spoon.
Spoon.
Cat.
Cat.
Ball, spoon, cat.
Ball, spoon, cat.
Good. So later I'll ask you to recall the words again. Okay? My biggest problem is as the examiner, I never remember to actually have them repeat the words again later. So my short-term memory is shot. All right? Okay, so good. So moving on from that, we're going to go to cranial nerves. Today for cranial nerves, we're going to practice it just by being able to know what to do to assess each cranial nerve. It's going to mesh a little bit differently when we get to eyes, ears, nose, and throat, but today you're just practicing the actual doing of these assessments. Cranial nerve number 1. Olfactory, which is smell. Patient's going to close their eyes, cover one nostril, give something underneath their nose. What do you smell? Then do the same thing on the other side with something else. Don't use anything that's irritating to the nose. So Dr. Heyman talks about like an alcohol swab's really irritating. Use something mild. Pick like a fruit, banana, excellent one. Everyone knows what that smells like and it's a very mild, non-potent smell. You're not doing it here, just tell me what it is, okay? Number 2, optic. Optic is eyes specifically vision, okay? So we have 2, which is vision, and then we also have 3, 4, and 6, which are eye movement, all right? So for 2, we're checking visual acuity and peripheral vision. We're gonna check visual acuity with a Snellen chart. These probably look familiar to you, maybe in a doctor's office, you see the big one on the wall where you actually stand 20 feet away from your patient. This is just proportionately smaller. It's gonna go 14 inches from your patient's face at their eye level, not yours, okay? It works pretty good with these. On the beds, you're above your patient, so be sure to get down at their level. So 14 inches in front of my patient. Cover one eye for me, please. That was not in Dr. Heyman's video. I'd like you to do it. Read the lowest line you can.
937826.
Excellent, and then switch to the other eye. If it's the same line, can you read it backwards?
628739.
Okay, good. So he's 20/25 in both the left and right eye. What does that mean?
You say you can see from one eye 20 from what the other can see 25 feet away or not?
Yes, that is what it means. So it's basically that the average healthy eye, we'll say, can see at 25 feet what he can see at 20 feet. If he was 2100, that would mean that the average eye can see at 100 feet what he sees at 20 feet. So he has to be significantly closer. 20/200 is legal blindness. Okay, so that's pretty significant. All right, next is peripheral vision. So for peripheral vision, again, everything with cranial nerve 2 is covering one eye. So if you'll cover one eye for me, I'm gonna hold up my fingers, add them together, okay?
2.
And the important thing is that he keeps looking at me
4.
and not using his eye to look. Okay, good, switch. Good,
2. 4.
great. Patients will try to cheat and they move their eye around to see where your fingers are. They have to stay looking at you. It's checking peripheral fields, okay? One eye and the other, top down, top down. Done with cranial nerve number 2. Cranial nerves number 3, 4, and 6 are oculomotor, trochlear, and abducens. In checkoff, you have to state every cranial nerve with its name, okay? I'll now be assessing cranial nerves 3, 4, and 6. Those are oculomotor, trochlear, and abducens, and this is eye movement. So for eye movement, first test is the big H. This is checking the muscles on the outside of the eye, your extraocular movements and your fields of gaze by drawing a big H. Get in front of my patient, getting him a nice midline, pulling his eyes, keeping his head still, and moving his eyes all the way up to the most that they can move, their full range of motion. And then back to the midline, and then the other side. Don't stop too soon, okay? You want to make sure they go all the way up to their full range of motion. Excellent. And then next for eye movement is actually pupillary movement, or pupillary ability to constrict and dilate. So I'm going to check that his pupils constrict. In the case of someone with brown eyes, it's sometimes a little bit harder to see their pupil. It blends in with their eye. So a trick is to make the room dark, and normally that helps. I think I'll be okay. So first assessing his right eye. This pen doesn't work. It works for like a half a second and then stops. There we go. Okay, he looks straight forward, coming in, and the pupil constricts. Excellent. Now same pupil again, but I'm actually looking at his other eye to make sure that there's consensual constriction of the opposite eye. Anytime your eyes dilate or constrict, both should do it, whether one or both are receiving the stimulus. Okay? Very good. And then same thing on the other side. Excellent constriction. And again, consensual. Excellent. All right, so cranial nerves 3, 4, and 6 are intact. Next is cranial nerve number 5. What is cranial nerve number 5? Trigeminal. Tri means 3. There are 3 roots in your face innervated by the trigeminal nerve. They are the temporal, which is up here on the top, facial, which is underneath the eye, and mandibular, which runs down the jawline. So we're going to check for sensation and along all 3 of those nerve pathways. Close your eyes and point to where I touch. Good. And when I do this, I'm checking the left and the right side of the face, and I'm checking all 3 temporal, facial, so it's hard with the mask, and mandibular lines. Excellent. Other part of trigeminal nerve is the strength of the masseter. So you're going to have your patient at their corner of their jaw here, have them bite down, and go ahead. Excellent. And I'm feeling for equal strength on both sides of the jaw as he bites down, which he has. So trigeminal number 5 is intact. 1, 2, 3, 4, 5, 6, 7. What's 7? Facial. Facial's weird with the mask on, okay? Smile. We're going to assume there's a smile under there. Frown. Puff out your cheeks. Now keep your cheeks puffed when I push against them. Good. And close your eyes. And resist me opening them. Excellent. All right. We talked, I think, last week about Bell's palsy, cranial nerve number 7 impairment that can mimic the looks of a stroke. So the patient may have a droopy eye, may not be able to close their eye, their face may be droopy, but it only affects their face. So sometimes when someone has that look, it's important not to just say, oh, it's Bell's palsy and not a stroke. A stroke is obviously much more important, so let's rule out the dangerous things. But it could be an impairment of cranial nerve number 7 if they cannot do those things, okay? Short of a CT scan and other things. All right, number 8. Vestibulocochlear or acoustic, that's your hearing. We're gonna do the whisper test. I'm gonna whisper him a 3-syllable word and let me know what it is. Occlude the ear, I'm not testing, so cover that ear. And
banana. Hospital.
Good. All right, so his gross hearing is intact. There's also the Weber and Rhine, or Weber and Rin, I'm not sure how you say it, test. I'm not sure, are they on your study guide or no?
Yes.
Yeah.
Okay, practice them today. They're not actually in your checkoff, but they'll be on your theory exam, all right? Weber test lateralization of sound. You're gonna give your tuning fork a nice little whap. Are you guys familiar with these? Tuning fork? Okay, they vibrate and they make sound. You hold it down here. If you hold it anywhere up here where it starts to make a U, you just stop it from doing what it's doing, all right? So you gotta hold it down here. Give it a whap, it will start to vibrate. It's gonna go on at the top of his head, midline, kind of at his hairline. Let me know if the sound lateralizes to the left, right, or both.
Both.
Both, good. All right, that's what we want it to do. Next is the RIN or RINE test. This tests sound from bone conduction versus air conduction. We're going to, should sound last longer through bone or through air? Through air, very good. So we're gonna first put this on the mastoid bone that's behind your ear. Give it another nice little love tap. Find the bone right behind the ear, place it there, and have him tell me when he no longer hears sound.
I don't hear it.
Can you hear that?
Yeah.
And then you would let it continue to sit there until he can no longer hear it. It'd probably take just double as long as it did for the first one. Okay, and then you would repeat it on the other ear. So practice it today so you understand it, but you won't do that one on check off. That's number 8. Now we get to combine 3 more, 9, 10, and 12. 9, glossopharyngeal, 10, vagus, and 12, oop, not yet, hypoglossal. Very good. So this is your mouth, your tongue, and your ability to make tongue movements that make speech, okay? So for this, we're gonna have our patient, he's got a mask on, but I would say stick out your tongue. When his tongue comes out, I'm looking that it comes out midline, doesn't go off to the left or off to the right. Then have him say ah. When I say ah with my pen light, I would be looking in his mouth at the uvula, that's your little punching bag in the back, and your soft palate, the roof of your mouth, and seeing that the uvula and the soft palate rise symmetrically, and again, nothing is deviating off to the left or the right. And then third, have my patient say light, tight, dynamite.
Light, tight, dynamite.
Excellent. When you guys say that, say it.
Light, tight, dynamite.
How do you feel your tongue? It's like hitting the roof of your mouth very prominently. I don't know how else to describe it when you say it. So if you had an impairment of cranial nerves 9, 10, 12, you would not be able to clearly speak those words, okay? And then last is 11, spinal accessory. We did that last week with musculoskeletal. Shrug the shoulders, equal strength, cranial nerve 11 is intact. Voila. Moving on, sensory, okay? So for sensory exam, we're going to do this on your patient's hands. There is L, light touch, pain, proprioception, vibration, and temperature. You're not gonna do temperature. You're going to do, and I tell students to remember it, LPPV, okay? So just tell yourself when you get to sensory, LPPV, LPPV. I don't know why, but it seems to work for people. All right, so when you get to sensory, just go through those. L is for light touch. Very similar to the trigeminal nerve. He's gonna have his hands out and he's gonna close his eyes. And remember with sensory, if he can sense at his fingertips the way your nerves run, from your spinal cord all the way down, okay, that if he can sense here, he should be able to sense here. If he can't sense here, then I'm gonna start backing up and find out where can he feel. But if he can feel this, then I'm not worried about what he can feel here, all right? You would technically do this on the fingertips and the toes, but we're not doing that. All right, so when I point, just lift your finger and show where it was. Very good. Good. Excellent. When I did that, I'm doing 3 different spots. You have 3 different nerves innervating your hand. You have the radial on the thumb, medial by the middle finger, and ulnar over here on the pinky side. So if you do the pinky, the middle finger, and the thumb for all these sensory tests, L, P, P, and V, then you will not go wrong, all right? You should technically do it on both hands, but just do it on one to save time. All right, that's light touch. Next P is pain. Pain is your ability to discriminate sharp versus dull. So you're gonna use a safety pin. I promise I'm not gonna hurt you. Close your eyes. I'm gonna first give him an example so he knows what to expect. So this is sharp, this is dull. What is this?
Sharp.
What is this?
Sharp.
What is this?
Dull.
Good, okay, pain. Next, proprioception. Proprioception is your awareness in space. Everyone here knows right now that their feet are down, their head is up. All right, maybe you go into outer space, your awareness of where you are is not so clear, all right? Close your eyes, hand out, taking the very last knuckle, okay, the very last knuckle of your finger with one hand to stabilize it on the sides, other hand to stabilize it on the outside, and I'm gonna give him an example. This is down, this is up. What is this?
Down.
This is up, this is down. What is this?
Up.
What is this?
Down.
Good. All right, proprioception is appropriate or intact. And last is V, vibration. Again, with your lovely tuning fork. Let me know if you feel vibration. Eyes closed, hand up.
I feel it. I feel it. I don't feel it.
Good, I stopped it. All right, so if you grab anywhere on the top part of your tuning fork, it will stop the vibration. All right, good. All right, that's sensory. LPPV, the last would be temperature, which we're not doing. Moving on to discriminatory senses. There are 5 tests. You will get 2 for your checkoff. I'm picking your 2 on the spot, so you have to know all 5. Okay, practice all 5 and know them by name. First one is graphesthesia. That's you're going to draw something in your patient's hand and have them identify it with their eyes closed. Hands up like he's reading a book. I want it to be fair to him by giving him a letter the way he would recognize it. Drawing a letter in his hand. This is an, try again. This is an O. What is this?
N.
Try again.
V.
Good. All right, then you would do the same thing on the other hand, graphesthesia. Next is stereognosis, your ability to identify an object with touch, not sight. So eyes closed, hand out. You can only use one hand, you can't pass it between both. What is that?
Safety pin.
Good. Eyes, keep your eyes closed.
Cotton ball.
Good. Kind of fun, you'll see. Okay, good. All right, so that's that. Next is point location. Same thing you've kind of been doing, only now it's over the whole body. Eyes closed. Big thing here is that I'm getting top, bottom, left, and right. Where did I touch you? Good. Okay, that's light touch. 2-point discrimination is your ability to tell if you're feeling 2 points or 1. And this is 2. This is 1. What is this?
2.
What is this?
1.
What is this?
2.
Good.
1. 1.
Yeah, it gets to a point, once you're about an inch or 2, nobody can discriminate down to 2 points anymore. It's kind of fun to try on each other. So it's an appropriate amount of 2-point discrimination. This he should be able to do. This he may not be able to do. Okay, it's pretty cool. And then last is extinction. That's your ability to recognize being touched on 2 different spots in your body at the same time, that your brain doesn't hone in on one and not be able to focus on 2 at once. Eyes closed. After I touch you, just show me where I touched you at. Good. Excellent. All right, so that's extinction. Some people, if you do that, it's like their brain can only focus on that one sensation coming in at a time, and they can't recognize both. All right, that's all of them. Last is coordination. Okay, 3 techniques. You'll be told to do 1. First is rapid movements of your hands. So you're gonna put your hands like this, flip them over, flip them back, and now keep going. Faster, 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 faster. Good. He's well coordinated. He's not getting disorganized. His hands continue to hit on his legs in the same spot every time. Good. Next is finger to nose. In front of your patient, eye to eye. My finger's coming out here. Touch your nose. Now touch my finger, staying looking at me. Back. And now close your eyes and keep doing it. Good. A student in the earlier class asked me, well, what happens if they're just slightly off? You know, they come just a bit off your finger. That's fine. It's that they have the fluid coordination to recognize approximately the area where your finger was. They're not going like this. Okay, there's a big difference there. So well coordinated. Last stand, heel to shin. Pick your heel up to your knee and then rub it down your shin to your foot. And I'm looking that he has a fluid motion and he's not uncoordinated and bouncing all over his leg or stumbling over. Some people don't have great balance, so they can hold on to something. It's more the coordination of the foot moving down the shin. Good. All right, last is gait. Can you walk over to that closet over there? Looking at his gait, looking at his ability to be steady. He's not ataxic in his movements. He's got good arm swing. Coming back on your toes, that's plantar flexion. Back to musculoskeletal, he's able to plantar flex his toes. He also has a steady gait. And now on your heels, like a duck. Dorsal flexion, and again the same thing. He's steady, he has good strength, and a good walk. Back in tandem or tightrope walking, heel to toe, eyes forward, don't look down. Someone with cerebellar dysfunction will not be able to do this, they'll lose their balance. Roadside tests, you know, when someone has had maybe too many drinks, okay, they won't be able to do that. Same thing with Romberg. Romberg, go ahead and stick your arms out like a zombie. Close your eyes and then stand there for 15 to 30 seconds. If he's not able to and he starts dropping his arm and swaying, that would be indicative of a cerebellar dysfunction as well, which he does not have. Negative Romberg test. Good? And that's it. Okay, so it's kind of fun today to go ahead and practice.